So good morning all. I welcome you all to the CME. The first session would be on fast therapy, a good Samaritan AMR crisis. The moderator would be Dr. Dilip Mathai, my mentor in ID. I welcome you, sir. Sir is the Director of Medical Education and Quality Improvement at Naruvi Hospital, Vellore. He is an ID physician at Center of Infectious Disease, Vellore. He was a former professor and head of medicine, CMC Vellore, former dean, Apollo Institute of Medical Sciences, Hyderabad. I invite sir to introduce the speaker and the panelist for today's session. Dr. Mallika, Madam, she is the principal of Indrani College of Nursing. Her field of interest are childhood infectious diseases, infection control, safety and management. Well, with a small brief introduction, we'll go to today's session. Fast therapy, a good Samaritan AMR crisis. Well, coming to the first case, a 45-year-old male, a case of type 2 diabetes mellitus, a CKD stage 5 from a LMIC. Patient was on dialysis for the past 5 years. Patient develops fever. Hence, the blood cultures were sent, which grew Pseudomonas aeruginosa 4 out of 6 bottles. The isolate is a multi-drug resistant. This is the AST report in Vitek, which showed this isolate is only susceptible to colistin. Hence, the patient was started on colistin. After 7 days of antibiotics, the fever never came down. The fever persisted. By 8th day, the liver parameters got deranged. Hence, the blood cultures were repeated, which grew again Pseudomonas aeruginosa, this time 6 out of 6 bottles. The ID physician said it has a persistent bacteremia, and the patient was continued on colistin. On day 8 and 9, the liver and lung function started failing for the patient, and the patient died of septic shock. On the 8th day, the culture sent grew Pseudomonas aeruginosa. This is the AST report. If you see the first report, which was multi-drug resistant, only working to colistin, by this time, the colistin turned out to be resistant. This slide is prepared from the document, 35th edition of CLSI guidelines. This shows the tier 1, tier 2, tier 3, and the tier 4 antibiotics. Since the patient is in LMIC and the hospital is from LMIC, they were able to afford only the testing of tier 1 and tier 2. The hospital and the patient was not affordable for testing tier 3 and tier 4. Sorry, this is a busy slide. This slide is prepared from the document on WHO Bacterial Priority Pathogen List 2024. This document stresses the bacterial pathogens of public health importance to guide the research, development, and strategies to prevent, control antimicrobial resistance. You see in this slide, particularly the second column is a Pseudomonas aeruginosa carbapenem resistant, and this document takes into some around 8 parameters, namely the mortality, the incidence, the total burden, degree of resistance, transmissibility, preventability, treatability, and pipeline of new antibiotics available for the isolate. This isolate, carbapenem resistant, our isolate of interest for this patient is carbapenem resistant Pseudomonas aeruginosa. Mortality is very high. Right? Our patient died. And pipeline antibiotics, if you see, it is very unlikely. So the verdict, this session would be, this chapter of the session would be affordability of newer antibiotics in LMICs, where it's very difficult, and affordability of testing for the newer antibiotics is also where resource limited. Where the resource is limited, our PHAGE will be a good Samaritan. Coming to the next case scenario, a 12-year-old male suffering from systemic lupus erythematosus undergoes a hematopoietic stem cell transplant for a T-cell lymphoblastic lymphoma. The post-transplant course was complicated with graft versus host disease. This graft versus host disease involved the GI tract and the liver. Patient was treated with steroids, immunosuppressive agents, tyrosine kinase inhibitors, monoclonal antibodies, and alpha-1 antitrypsin. All this led to a highly immunocompromised state for the host. The patient develops fever. Again, blood culture sent grew Enterococcus faecalis and Streptococcus salivarius. Patient was treated with ampicillin and cefepime. Here, the source of infection is because of immunosuppression. The gut flora got translocated. Enterococcus, you see Enterococcus, a gut flora, it got translocated, which causes the bloodstream infection. On day 65 of transplant, post-transplant, patient again developed signs of sepsis. Blood culture sent. This time, the new pathogen is Escherichia coli. 6 out of 6 bottles Escherichia coli group. AST report showed some multi-drug resistant and an NDM producer. The patient was started immediately on ceftazidime avibactam azithromycin. The patient became afebrile. It's a good news. But how far the good news lasted? Not long. On day 91, patient again develops fever. This day 91 is post-transplant. Patient again develops fever. Blood culture sent. Again, the same villain, Escherichia coli. AST report showing ceftazidime avibactam azithromycin. This drug is resistant by the shows resistant by the isolate. Hence, the patient was started on cefiderocol. Patient became afebrile. So it was on day 91. In maximum span of 10 days, again the patient develops fever. Blood culture sent, grew Escherichia coli. This time the isolate is resistant to cefiderocol. Previously, first when Escherichia coli grew, it was sensitive to ceftazidime avibactam azithromycin. So patient was started on that. Within a span of 10 days, the isolate developed resistant to ceftazidime avibactam azithromycin. Hence, the patient was on cefiderocol. Within a span of another 10 days, the same isolate proves to be resistant to cefiderocol. By nearly 101 days post-transplant, the condition slowly deteriorated. Patient became progressively acidotic, requiring escalating pressure support. The patient was maintained on tobramycin and polymyxin B. Condition deteriorated and the patient died of septic shock. Post-transplant, the patient survived for 105 days. So this is the slide prepared from CLSA document, 35th edition, M100, a recent, it came outside. So tier 1, tier 2, tier 3, and tier 4. Since the patient is from high-income country, the hospital and the patient was affordable for testing and for administration of tier 3 and tier 4 antibiotics. Everything was done at our end. Microbiology and the physician, ID physician have done their role, but the patient was unable to withstand the battle because of the immunosuppressed state. So this is a sample isolate showing isolate resistant to ceftazidime avibactam, ceftazidime tazobactam. It's a pan-drug resistant isolate, sample isolate, which is a pan-drug resistant. The first case is a real-life case scenario, which I saw in my fellowship period. The second case I have taken from the Clinical Infectious Disease Journal, published by IDSA. This is a case from a sequential treatment failure with azithromycin, ceftazidime avibactam, followed by cefiderocol, due to pre-existing and acquired mechanisms in a New Delhi methyl-beta-lactamase producing Escherichia coli, causing fatal bloodstream infection. Again, coming to our busy slide from WHO document, concentrate this time to concentrate on the fourth column. Escherichia coli is a carbapenem-resistant isolate. Mortality is medium to high. Anyway, our patient died. And the pipeline antibiotics, few promising pipeline antibiotics are there. Ceftazidime avibactam, azithromycin, cefiderocol. But how far they were efficacious in our case? Left to you to decide. The verdict of this chapter would be, in immunocompromised state, AMR makes the battle even harder. We need a different arsenal. When we're looking for a different arsenal, PHAGE will come as a good Samaritan. So these are the stories of AMR. Plenty of stories of AMR do exist. In all these stories, we humans die and the villains, our escape, they win and we lose to them. So newer antibiotics, when newer antibiotics are promising, newer antibiotics are coming up. How far these are effective? When we say newer antibiotics, we hear a term newer antibiotics, we think we are going to mitigate AMR and walk against AMR is going to be a cakewalk. Is it so? So what promising newer antibiotics we do have in our upcoming market, or we do have in our market is nafithromycin. A lot of antibiotics are going to come up. Cefepime in metazobactam, ceftazidime avibactam, avibactam azithromycin, sulbactam, darlobactam, cefepime, zirabactam, meropenem, viberbactam. So many BL-BLA combinations are coming up, and levonodifloxacin and levonodifloxacin. So much list is there. But whenever anybody says a newer antibiotic, three things must come to your mind: availability, affordability, and duration of effectiveness. Is it available in LMIC? Because the major brunt of AMR is going to be in LMIC, Africa and Asia. Is it available in Africa? Poorest of the poor, are they affordable to this antibiotic? First point. Affordability. Are they affordable? whether the hospitals are affordable to test. The lot of microbiologists have joined today. Very happy to see majority of the participants, very short notice, 115 participants have joined. Right, so affordability. So any new antibiotics they come to the clinicians for introduction. The clinician, when they meet the clinician and they give the AST disc to them, and they give to the microbiologist to test and see how far this efficacious, how far this antibiotic is going to be efficacious in our hospital. Every microbiology laboratory has a repository, biorepository of the isolates. They test the efficacy and we give the report. Right. So whether our labs are affordable to test it, and duration of effectiveness. Newer antibiotics, when we hear a lot of antibiotics have read out, so you may think, yes, newer antibiotics are going to come, we are going to treat infection. The second case, what got published in IDSA, cefiderocol, how much long it was working? 10 days. Ceftazidime avibactam, another 10 days. I am not saying this, the efficacy is low. Only the case history. I am just referring the case history. The effectiveness is maximum, it works for 10 days. So it's a battle. It's a battle between the bacteria and the humans. Humans evolved, the survival of the fittest says, Darwin's theory, survival of the fittest. The survival of the fittest, we evolved to fight the bacteria, and we evolved and we fight because we have to survive. So bacteria makes a revenge on us. It fights against us. So always one thing we have to agree, whether we are smart or bacteria are smart. When in the evolution cascade, they came first. Bacteria came first and we came next. So definitely they are smarter, right? So this cefepime N-metazobactam, the new antibiotic, the promising antibiotic BLI is coming. The founder, Dr. Manish Pal, I was able to meet him in a G-Spark conference organized by IFCAI. A lot of people organized it. To my well-known people, to me is only two stalwarts in IFCAI, Dr. Rangareddy Buri and Dr. Pranav Kumar. They made a platform for me to meet Dr. Manish Paul. I met him. He said it took 18 years. See, mark my words, it took 18 years for cefepime N-metazobactam to come to our hands. The same thing, ceftazidime avibactam would have taken the same time. All these antibiotics would have taken the same time. See how fast our bacteria develop resistance. Not even days. It just takes days to develop resistance. We take 18 years to develop an arsenal to fight. It just takes days to nullify our arsenal and makes our arsenal futile, right? So was this prophesized? Was this antibiotic resistance prophesized? Or phage therapy would be a good Samaritan prophesized? So in 1908, Paul Ehrlich said, drug resistance follows the drug like a faithful shadow. Again, the point to note is 1908. In the year 1908, drug resistance follows the drug like a faithful shadow, Paul Ehrlich said. When did the human receive the first antibiotic? Anybody, the online participants can just put in Q&A session. Let us make this session active. Let us see how far people are interactive and active, because it's Sunday. Thanks, it's a Sunday, it's a holiday. We like to spend our time with our family. But if all of us have joined to fight against AMR so that we save one life, that's really that gives a meaning for our life, right? In 1941, it was 1941, the first human to receive penicillin. But 1908, he prophesied it. And the thoughtless person playing with the penicillin treatment responsible for a man who dies with infection. This was a statement made by Alexander Fleming in 1945 during his Nobel laureate speech. So he is Dr. Manish Pal, met him in IFCAI, G-Spark, organized by IFCAI. He was saying 18 years, our bacteria develop resistance in 10 days. So in this is Albert Alexander, the first policeman, the first person, the first human. So he was a policeman who received the penicillin. First 4 days, penicillin was available. He got a cut injury. His infection was overwhelming, and this antibiotic was working. But the sad part is that we ran out of stock of antibiotics. So what happens? The infection he got reinfected, and we could not save, and the patient died. So in 1941, penicillin was given. This is publication stating that 1942, Escherichia coli strains were isolated, which inactivated penicillin. And 1942, Staph aureus resistance. 1941 penicillin came. Within 1 year, resistance was seen. And 1960, 80% of community acquired and hospital acquired strains were resistant to penicillin. So here, the verdict of this chapter would be of my presentation. However, and whatever may be novel antibiotic be, you come with any antibiotic. Bacteria says, I have the final laugh. You humans are nothing in front of me, because this is a fight, right? We must know our enemy. Whenever there is a fight, we must know first the enemy and the strategy, what we are going to have. So whenever we talk about war, the world is at war right now. So war, Sun Tzu is a Chinese military strategist. The ID physician, we always refer this. This was introduced to me by my ID mentor, Dr. D. Suresh Kumar, co-founder of List of ID. In his presentation, he always quotes about the Art of War, the book of Art of War made by Sun Tzu. He said, if you know your enemy and you know your strategy, you are going to win every battle. If you know your enemy, but strategy is doubtful, you are going to lose a lot. If you don't know your enemy and you don't have a better strategy, you are going to lose everything. You are going to succumb to that war. So the enemy is bacteria. The strategy is antibiotics. So our enemy is very smart, right? This is a war. Antimicrobial is a war. We know our enemy. Enemy is very smart. You come with any arsenal that we are not going to win. Strategy, new strategies, but it's only time being the strategy works. Time we take 18 years or 15 years together, we may work up a strategy, but within days the strategy is exposed to our enemy. So here we must fool our enemy so that we bring in a different arsenal, or a person who co-evolved with our enemy. That's nothing of PHAGE, right? So PHAGE resistance, we talk about antimicrobial resistance. PHAGE resistance, whenever we say about PHAGEs, immediately people say, you're talking about AMR, you say PHAGE, but what about PHAGE resistance? PHAGE resistance, to me, it's a misnomer, right? So for particular bacteria, you isolate a PHAGE and we give it. So PHAGE will work. If it's not working, that means your isolation there is a problem. It knows bacteria and viruses are neighbors, right? How bacteria evolves, it knows. In the similar way, PHAGE also will evolve. And to me, PHAGE resistance will not happen. Right. Coming to the next session. The person who takes medicine must recover twice. Once from the disease and once from the medicine. The famous quote from the father of medicine, William Osler. We microbiologists, we go according to our father, Louis Pasteur. So this is a physician. William Osler said, a person who takes medicine must recover twice, once from a disease and once from the medicine. Antibiotics, when we give, always one complication every ID physician or every physician will have in their mind is C. difficile, Clostridium difficile. Oh, sorry, it is Clostridioides difficile. Right, see, when I learned it was Clostridium difficile, now it is Clostridioides difficile. Still, this Clostridium is coming in my mind. The same way, all are physicians been trained to give antibiotics. When we say about PHAGEs, it's very difficult. So it's our duty, microbiologist duty, whenever we dispense a report, a pan-drug resistant, definitely you will be getting a call in corporate setup or anywhere you get a call from the physicians. Doctor, you have given a report as pan-drug resistant. None of the antibiotics are going to work. What is the option left over? Just educate them and advocate them about PHAGEs. Then next question will be coming from the physician. Where do I get PHAGEs from? For that, you have the climax of this today's CA. So this is the initial opening scene. I believe I'm making it maximum to the interesting point of view for the participants. So climax will be very interesting. So for a successful movie, the opening scene is very interesting so that you will sit for a long time. And the climax is very, very important. The climax is also very important. You have very eminent speakers. All the 6 speakers are very eminent because this CME is not like other CMEs. You just come, get the certificate and go. Whatever the knowledge you're going to this CME is going to save a life of a patient, which others cannot do. Right? We are all joined together. It's not one man's race, one person do. No. It's all, we are fighting a pandemic. Pandemic is always a teamwork. Pandemic preparedness, everything is a teamwork. COVID was a pandemic. We have never been warned. This is what put them in the brochure. We have never been warned 25 years ago that there's going to be a pandemic of COVID-19. Had it been there, we'd have prepared something, would have saved a lot of life. Microbiologist, the role of microbiologist, And the, what is it, glory of microbiology went up during the pandemic, right? Our reports went, our report, people are waiting for our report. You want to go for international travel, get our report, right? You want to go for a meeting, get our report. People died, pathetic. It was so pathetic to see. My ID physician who has joined as some moderator said to me, the most pathetic death for a man is that lack of oxygen. He taught me during my fellowship period at Madras Medical Mission. He was one of my mentors. Right. So that was very pathetic that people died, lack of oxygen. I was a COVID nodal officer in Venkateswara Medical College. I saw people dying there. Right. So I used to see Boston, given an opportunity, I did something, but we were not warned. Now, already the AMR pandemic is there because COVID killed 30 lakh people in a year. Totally 60 lakh people all around the globe we lost in 2 years. In 2024 alone, 50 lakh people have died. That's the reason why this is called a silent pandemic, because no media covers and no public knows about that. Now, another 25 years are there. 2050, full swing is going to happen. Full swing. What can we do? What is the pandemic preparedness? As a microbiologist, as a physician, as a doctor, what can we do? This CME will help you out. More thankful to the IAM Pondicherry chapter, Best of ID, and the Society of Bacteriophage Research in Therapy for helping us out, for coming out the CME, right? In a very planned manner. Whenever you talk about Clostridium difficile infection, 4 things must come to your mind, 4 drugs: metronidazole, vancomycin, fidaxomicin, and fecal microbiota transplant. I don't see any ID physician prescribing metronidazole. Usually they go for vancomycin. So vancomycin has been given. The article comes at an IDSA saying that reduced vancomycin susceptibility. So vancomycin is losing its shape. Next is fidaxomicin. Availability in LMIC, question mark. We are talking about recurrent Clostridium difficile infection. For recurrent Clostridium difficile infection, RCT is being conducted on fecal microbiota transplant. Again, affordability, availability in LMIC, the question mark. So, verdict of this chapter would be, we need a surgical strike. ID always teaches, the first thing in ID is syndromic approach. Patient says something, first pin down which syndrome is, which system is getting involved, come for a syndromic approach. This is what the ID physicians teach me. This is what I was taught. Syndromic approach. Any antibiotic you give, it is going to touch your microbiome. Without touching microbiome, can you just say any one antibiotic which is not going to touch your microbiome? No. So any infection is there, we need a surgical strike. Surgical strike on the offending pathogen is needed. So it is the need of the hour. Any antibiotic you give, which is going to affect your microbiome. So we don't need that one. PHAGE will not touch your microbiome. As a microbiologist, we have been, as a student, first MBBS student, then microbiologist, PhD research scholars, we have been taught and we have been teaching only about the good bacteria in the gut. What I say today, that you have bacteriophage in your gut also. Those are called as good viruses, bacteriophages. That community is called as phagiome, right? So phagiome is there. Once the good bacteria dies, your phagiome is disturbed and you'll end up in all sorts of problems. So whenever I talk about microbiome, lot of research is going on. If you closely follow IDSA articles, one of the modality to mitigate AMR is to replenish the lost microbiota. That is also one of the modality. So microbiome is very important. Whenever we talk about microbiome, we have been taught there is something in the gut. You have a microbiome in the brain also. Still research which do, I think the entire body is full of microbiomes, right? Research, that's what we say, when you go deep into research, you come to know about your ignorance. So in this chapter, we'll talk about microbiome. Once we touch the microbiome, what happens? Antibiotics are being given, what happens? The patient lands up in obesity, diabetes, allergy, autoimmune disorders, neurodevelopmental disorders in children, and certain cancers. Very worrisome, right? Very worrisome, these cancers. So this picture is taken from 2014, right? The years are very important. 2014, there's a report from WHO stating that AMR in 2050 is going to take 10 million. It is in 2014. Now it convert to Indian, what we say is 1 crore. 1 crore people are going to die in 2050. Now articles are surfacing as 4 crore. We don't know what is really going to happen in 2050. And cancers was predicted to be 8.2 million in 2014. So this is in 2024. American Association of Cancer Research says in 2050 it is going to be 18.5 million. In 2014 it was 8.2 million, and 2050 it is 18.5 million. I don't know what is going to really happen in 2050 because of cancer and AMR. So this cancer and AMR, I believe it is going to wipe off half of the population like what Thanos did with a snap with the 6 infinity stones. I believe with 6 is not needed, just 2 is needed. 2 is enough. AMR and cancer, these 2 infinity stones are enough to wipe off half of the human population. So one calculation says that every minute 40 people are diagnosed with cancer, right? And cancer turns the lives upside down. People who have worked microbiologists in cancer centers, you see people, it's very devastating. Once the patient you have been labeled as cancer, the life turns upside down for them, right? Particularly in LMIC, poor people, right? Affordable with insurance, okay, they can run the show. And AMR makes the battle even harder. We have been talking about COVID pandemic, AMR pandemic. One more silent pandemic. What we say is colorectal cancer is really a pandemic. The article says colorectal cancer is a pandemic. So many reasons we can put forth. One reason is antibiotic abuse, not use. We are not against antibiotics. Today I'm 40, I'm standing in front of you. It's because I have taken antibiotic for my infection. I am surviving. Right. So judicious use, that's what we say, judicious use. At times, we need a fast therapy. That's a good Samaritan. So the verdict of this session would be we need an alternate arsenal to fight infection in cancer patients. Next chapter would be on emerging nosocomial pathogens. As a microbiologist, we see samples from immunocompromised people grow different types of organisms. They grow different types of organisms. All new terminologies, right? New terminologies. We read that organism and we see whether this organism really will really cause some infection. Then we come across some case reports. Yeah, that too causes. Whenever this emerging nosocomial pathogens come in VITEC reports, 2 things must come to your mind: biofilm formation and intrinsic drug resistance. These bugs are intrinsic drug resistant. So once they are intrinsic drug resistant, we are left out only with very handful of antibiotics, very handful, only handful of antibiotics. How long this handful of antibiotics are going to work? Bacteremia, we divide into complicated bacteremia, uncomplicated bacteremia. Uncomplicated bacteremia, IDSA guidelines is 7 to 14 days of antibiotics, and complicated bacteremia, 6 weeks of antibiotics. These nosocomial pathogens will end up in causing bacteremias, usually complicated. We need 6 weeks. And we saw a case of cefiderocol, ceftazidime, avibactam working for 10 days. And this Stenotrophomonas maltophilia, I will not forget this organism. It is because this organism I encountered during my fellowship in a patient, which made me to take interest in PHAGE. And today I am a PHAGE enthusiastic today, I'm standing in front of you. And biofilm formation. Biofilm formation. These organisms are more prone to form biofilms, and majority of antibiotics find very difficult to penetrate into the biofilm. So this is the CLSA guidelines. We saw the enterobacterales CLSA guidelines, Pseudomonas. We had a lot of antibiotics, right? Tier 1, Tier 2, Tier 3, Tier 4. All the 4 tiers, we had some at least named 2 or 3. But here, if you see for Stenotrophomonas maltophilia, 35th edition of CLSA guidelines, we have only 4 antibiotics. How long this 4 going to work? If a patient lands up in Stenotrophomonas maltophilia bacteremia, left to you to decide. In these cases, we need PHAGE as a good Samaritan. Do we have PHAGEs for Stenotrophomonas? Yes, we do have PHAGEs. Dr. Shobhana Sukumar has done a work. She is also joining our session, our CME today. She is from SRM Katangaluthu, an Indian who has done a work on PHAGE. So PHAGEs, you ask where the first PHAGEs was discovered, where this PHAGEs came in. It's all from India, all from Mother Ganges, right? And today we question how far PHAGE is going to be effective. Left you to decide. It's all from India, and India is majority of the death from AMR is going to be from India. We saw PHAGEs from India, and it's our duty to make PHAGE as a therapeutic option. It's all we have to request ICMR through case reports to clinical trials to make PHAGE therapy a promising therapeutic option in India. The verdict would be of this session would be emerging nosocomial pathogens need plan B. The plan B would PHAGE therapy, would be PHAGE therapy. Uncle Sam, everybody knows about him, right? Uncle Sam said WHO funding for WHO to be ceased temporarily, and he asked CDC to not work with WHO. So whenever anybody says about WHO or CDC, one thing comes to your mind: vaccines. COVID promoted adult vaccination. Whenever you put adult vaccination in Google before COVID, you always see a mother holding a child for polio, right? As an adult taking a child for polio. This is what the picture you get in Google, adult vaccination if you put before COVID times. After COVID times, a lot of adult pictures came for receiving Covaxin, Covishield, whatever the vaccine they got. So whenever we talk about WHO, CDC, adult vaccines come. So once the funding dries up, it's very difficult for vaccine trials to come outside. Adult vaccination is a promising option to mitigate AMR crisis because you give vaccine, you're not going to end up in infection. There is no infection, no abuse of antibiotics. No abuse of antibiotics, no growth, there is no threat of AMR. But what happens when funding reduces? The funding reduces for vaccines, vaccine trials, vaccine innovations. When this goes down, so this low-hanging fruit, what I say, adult vaccination, low-hanging fruit, but it's very difficult, right? Lack of funding makes this cost-effective low-hanging fruit unreachable for us because of lack of funding. The final chapter of this session of my presentation would be, we must reach the public. AMR, if we talk about AMR has become ad nauseam among the medical community. We know about AMR, hand hygiene, we say, World Antibiotic Awareness Week, we say. So we have to reach the public. That is very important. This picture, this every day during COVID, I am from Pondicherry, Union Territory in Tamil Nadu. So during COVID times, from government of Puducherry, we used to get daily statistics like that to the COVID nodal officers. How many people are suffering from COVID? How many people are there in the hospitals? How many people have recovered? How many are in oxygen beds? How many are there in orange, green, and red zone? How many people are in ventilator beds? How many ventilator beds are free? So all the statistics was given. And we used to disseminate to all our people. So like this is a humble request I put to all the microbiologists who have joined, participants who have joined. Let us approach our local IIMM chapters. Through our local IIMM chapters, we will reach our president, local IIMM president. Through our IIM president, we will go to IIMM. Through Indian national body, we will reach the government like this. This is my request, right? It's very easy to say, but how far is going to be implemented? It's left to the stakeholders to decide. It's humble request from my side, and I request all microbiologists to join hands together, all the participants, all the healthcare professionals, not only microbiologists, doctors, pandemic, it's staff nurses, everybody, all healthcare, everybody, please join the hands. Humble request from my side. Can it be like this, right? So why can't every day we get a data? Every day we get a data. How many people are affected with SKP pathogens? Right? How many people are affected? How many people are in the bed? How many people are discharged successfully? And how many have succumbed to death? But this will create an awareness for the public, and they will say why this death has happened. So abuse of antibiotics, and they will stop asking for unnecessary antibiotics. That is what it may work. This is one of the things I wish to say in this CME. And we all watch movies, right? So if sit for a movie, this advertisement comes, right? Smoking causes cancer, smoking kills, consumption of alcohol injurious to health. Our favorite hero, villain talks this one, right? And consumption of drugs. This is from a movie. I am not cooking up something, right? I put the movie reference for you also. Consumption of drugs. All these awareness statements come. Riders riding four-wheelers without wearing seat belts, punishable offense. Violence against women, children, everything is there. But anything about AMR. So can we do, right? Profligate use of antimicrobials result in AMR pandemic. judicious use of antimicrobials are needed. Can it be, say, 1%? This is just through this CME under the auspices of IIM Pondicherry chapter, best of ID in SBRT, a small stone is being thrown in the pond. Whenever the small stone falls in a pond, the ripple created, initially it will be very small. The ripple created initially will be very small. If you see the same ripple created, the place where the stone fell, and when it reaches the bank of the pond, it will be very big. Right. So this is the small ripple I wish to create. Why this AMR pandemic awareness taken to our cinema theaters? CBFC. I don't know. I'm not a big expert of these accreditation bodies. It's through us. Why can't we? Some people with face value can go with it, right? So this will help us to mitigate AMR. So this is a multi-pronged approach, a multifaceted approach. So it's a war. It's a war. Everything is fair in love and war. This is what the famous saying said by an English politician. So it's a war. We are fighting against bacteria. What all possible ways? This is what my mind made me to think. When why is clear, we know why this AMR, how is easy now. How to mitigate is easy. Let us not become an endangered species, right? PHAGE will help us, right, not to become an endangered species. So this picture shows where is going to be the maximum brunt of AMR. Asia and Africa, LMIC countries. And rather than holding a placards like this, I lost my kith and kins in AMR, let us promote PHAGEs and let us help, let us daily put some efforts, let us all join hands to put these efforts through the CME or with our supporting hands to SBRT. They are trying a lot to make this PHAGE therapy an approved option by ICMR in India. Let us all join hands with them. And so this is Ubuntu, the picture Ubuntu, is a famous African thing. Everybody would have come across this one. Majority would be familiar. So the thing is that Englishman gave a mango, kept a mango near a tree and asked some 10 children, whoever reaches the tree first gets the mango. All 10 joined their hands and ran together. And the Englishman asked, how come it is? One would have come, would have got the mango. But 10 said, see, one person is happy and other 9 are sad. We don't like that. We want everybody to be happy. The same way, maybe some 115 people know about PHAGEs today. Other people know about what. It's not that only few people in India or few people in one part of the world know PHAGEs. Everybody all over the world must know about PHAGEs. When there is an infection, when antibiotics fail, we need PHAGEs. At sometimes, PHAGE first, antibiotic next. So this is all we all run together for a pandemic. And we are all waging a war. The enemy we know is the bacteria. Right? What is the strategy? It develops resistance. So we must know the enemy. Do we know the enemy now right now? Yes, we know the enemy. We know the strategy is devised, out for its failing. What are the loopholes? Are we now ready to address our strategy? Yes. Once we know our enemy, we are know to address the strategies. Definitely, we are going to win the war against AMR. Right. So these were my mentors. Today, I am talking about PHAGEs. It's because of my mentors, Dr. Anusha, who is in the center, who got the Pfizer funding. It is because of her I was able to meet these two doyens in ID. Dr. D. Suresh Kumar, Apollo ID physician and co-founder of Best of ID, and Dr. Dilip Mathai sir, who has joined as moderator. Because of these 3 people today I talk. And Dr. Dilip Mathai sir used to say, there must be a purpose in your life, Gerard. He said to me, what is your take-home message after your fellowship? I said, sir, I want to pursue my career in PHAGE therapy. Good. He said, good, go ahead. Today, he has come today as my moderator. How lucky I am. Sir, thank you, sir. So, PHAGE, all watching us, all petty fellows, talking about MDR, SKP pathogens, right? You come with new antibiotics, they are going to, I'm just give me an option. Just give me a call to ban, to manhandle everybody. PHAGE is not only a good Samaritan AMR crisis, they are a good Samaritan always, right? So this is the latest one which I came across. Ganga kills germs 50 times faster. Study finds 1,100 bacteriophages were there to naturally purify the water. The Mahakumbh. So everything is there in nature. You go with nature, be with nature, you will be a human. Rather than saying thank you, I say PHAGE to all people. Thank you and PHAGE.
Thanks. Thank you. Thank you, Professor Gerald.
Thank
On
you.
a Sunday morning, you are a pulpit speaker. You have chosen a biblical topic from Good Samaritan, worked down the ages to antibiotic discovery, and then you work down to the present AMR crisis, and you have taken us beyond Viksit Bharat 2050. So it's a very, long or expanded time span that you have covered in this talk. Very good stuff. Now that you have mentioned this, uh, you have also chosen certain conditions that you are seeing in your practice, that is multi-drug resistant organisms. Now, we should also look at it as, are they truly exogenous or are they truly endogenous organisms? The problem is that exogenously, where is it coming from? It is the hospital environment. And endogenously, it is because of using, well, let's say multiple antibiotics at a different dosage levels, etc. So, where do you think the real root cause is exogenous organism or endogenous organism, and who creates it? Once you have an understanding of that, then you can decide where you want to put your money. Should we put our money in AMSP or should we put our money in hospital infection? Well, Paripasu with discovery of new antibiotics, these two would also have to go hand in hand. Now you have brought us to a need for a newer antibiotic or a newer alternative, which is a very good thought process. In my association with you over the last 3 years, you've been very passionate about bacteriophage therapy, and I was not so, moving along with you. But this is an alternative therapy that we have to consider. The advantages are tremendous. You offer a targeted approach. You offer a targeted approach to an organism which the microbiologists have to first identify. If the microbiologists do not identify the targeted organism, then we clinicians can do nothing with any newer antibiotic or any newer discoveries that we have. So the third important area is beyond AMSP. Second one being infection control. The third one is better diagnostics. You should be able to grow the pathogen. Then you can look at targeted therapy as such. And there is a great role for bacteriophage therapy, particularly because, as you have alluded to it, that the human microbiome will not be damaged like the broad spectrum antibiotics that we use today. Penicillin was okay, it was a very narrow spectrum. But all of these antibiotics that come out are more on the in the broad spectrum. So we have to be careful, and that's the second major advantage with bacteriophage therapy. It will be obvious, I think, maybe not having too many adverse reactions. We have to try it out, but you will not damage the present microbiome, whether it is intestine or whether it is in the respiratory tract as such. Now the stage is set for the day. How does this phage therapy work? What is the utility of the phage therapy? Utility I understand, but I am not too sure in acute infections, bacteriophage therapy. Chronic infections like TB, it may be with the multi-drug resistant TB. It will be perhaps useful in preventing Clostridium difficile infection, but whether to eliminate from Clostridium difficile infection or not. But like you alluded to, there will be lots of challenges and considerations. Funding. Where are you going to get the funding? Where is the specificity? Who is to decide it? And regulatory body approval. It's going to take a long time, but uh, I think it is something, a line that we should move forward into. Perhaps, perhaps the first stage should be in animal health because a large quantum of antibiotics is used in animal industry. So if you can start with the animal patch therapy, or because they are not using it for treatment, they are using it for prophylaxis. So I think the first role would be in patch therapy in animal health. And then it's your medical college where you are all working in, is to build PHAGE libraries. Would you be cooperating? Will one cooperate with another person? Just now you heard about US not cooperating with WHO, the world body. You know, would you build PHAGE libraries and would you share it? Very easy for us as teachers, we can very easily educate future generations in PHAGE therapy, and that should be the focus and of your introductory talk, and mix and sensitize all of us, the medical students, postgraduates, into a good alternative therapy, which is namely PHAGE therapy. So this would be my comments, and I just want to set the stage on how this PHAGE therapy works, the utility of PHAGE therapy, the challenges and considerations that you will be seeing throughout the day, the WHO's critical priority pathogens, and all of this. So may I ask my colleague panelist, Maliga, to make her comments also on this presentation? Anyway, so I think, thank you very much, Professor Rakesh, and I think we should move on to the next presentation.
Yes, sir.
And let the day progress. Looks like you have a great agenda planned out, and I will be moving in and out to hear all of you. Thank you very much for inviting me to be a moderator for your session.
I am more humble and honored, sir, to have you as my moderator. Thank you, sir.